of comorbidities change the outcome in our patients? Does it change the approach with which we treat these patients? So we're going to talk about that. So asthma is a common chronic disorder. We all understand there are more than 300 million people over the world who are affected by it. And in India, we think about 5 to 10% of our population suffers from asthma. And then initially we thought that it's an allergic disease of the airways, and you control inflammation and everything goes all right. But now we understand that no, it is not like that. It's a heterogeneous syndrome and it has distinct phenotypes into it. That is what we are going to talk in our presentation now. So it does have a lot of impact on the asthmatic patients. This is like an interesting chart showing the prevalence, incidence, the DALIs that are related, disabilities that are there, and deaths which are there. And you see, there has been no significant change that has happened between 1992 to 2017 in anything. We are still there. A lot of research happened, a lot of marketing happened with inhaled corticosteroids, newer delivery methods came in. Like so many things have come in. But the picture has remained the same, means we are still doing some mistakes in treating such patients. We are still not right on track where we should have been. There should have been a falling trend in all these curves, which has not happened. So that gives the food to thought that are we like not looking at the picture correctly? Are we not putting up the right approach in treating such patients? And one of the things that have been talked of now in treatment of asthma is emerging is like comorbidities which are there. So the comorbidities that we want to talk about is obesity, which increase asthma risk, and it does complicates clinical asthma. Patient gains weight because of less exercise and asthma becomes worse. Metabolic syndrome increases asthma risk. Diabetes increases asthma risk. Mental illnesses increase asthma risk as well as complicate the management of asthma. Cardiovascular diseases, these are like found in higher incidences being found in asthmatic patients, and especially in adult onset asthma, we find it more. And if the patient has comorbidities like gastroesophageal reflux, allergic rhinitis, a history of skin atopy or other atopies, vocal cord dysfunction is like one of the comorbidities which are like quite often missed because it's like difficult to analyze till you do a direct laryngoscopy. Smoking, which is so common now, and of course COPD, which is like something which is one of the other. It's like if you talk of obstructive airway disease, the other major part of obstructive airway disease is COPD. And does they coexist? Do they coexist, or they are like the part of same spectrum? We are going to cover today in our talk. So relationship of asthma and its comorbidities, if we like try to lump them, first is like which share common pathophysiological mechanism. So allergic rhinitis and bronchial asthma have same kind of pathophysiology mechanism in the background, and it's like few patients complain of having asthma onset before allergic rhinitis, and few people say that they had allergic rhinitis from past 8 years, 10 years, and now they are experiencing cough or breathlessness, and you do a pulmonary function test and you find airway obstruction with reversibility. So a common pathophysiological mechanism is there. Second is which influence asthma control, makes it a different phenotype, and changes the response to treatment. But they don't have a common pathophysiological mechanism. And the third, which is the disease which is there and it doesn't have any obvious influence, but it does impact the outcome. So it's like it's more prevalent in asthmatics, and it does have an influence on patient's life, but then it doesn't interact directly with each other. So the metabolic and inflammatory component that are common to other diseases, like in obesity, metabolic syndrome, or diabetes, cardiovascular diseases, these have an interplay with each other, and these are more commonly seen in adult onset asthma, not in the childhood onset asthma where you find these to be more common. So there is probably a link which we don't understand yet, but then what we understand that these inflammatory or metabolic components which are there in other diseases does have a interplay with asthma and does impact the management and the outcome in such patients. So obesity is a risk factor for childhood asthma in obese, and asthma becomes difficult in obese patients in terms of their control. You will see this that patients who are like clean and thin, when they gain weight, the requirement of their inhaler dose goes up. And how does this happen? It's like still not very well understood, but there could be contributory comorbidities which come up with obesity, like obstructive sleep apnea, which is more common in obese people. Gastroesophageal reflux is more common in obesity, or it could be mechanical factors, the restriction which is imposed on chest because of obesity, or undefined factors which I said that we really don't understand the interplay so nicely. And these all lead to breathlessness, and actually your patient came to you for breathlessness. A patient doesn't come for diagnosis. We are always interested in diagnosing patients with a labeling them with a diagnosis, but then patients always come to you with a symptom, and if the symptom is not controlled, the purpose of the patient coming to a doctor is defeated. Patient wants symptom control. Gastroesophageal reflux disease, it's like the most common symptoms for GERD is heartburn, epigastric or chest pain, but then it causes dry cough, which is quite common. Patients complain of dry cough, especially at night. And it is found to be more in patients with asthma. And then it becomes difficult because asthmatic patients do also have dry cough, and GERD patients also have dry cough. So the cough is that you're attributing to asthma maybe because of gastroesophageal reflux, and if you don't treat it, things become haywire. Patient doesn't get improvement in their cough. And some asthma medications such as beta-2 agonists or theophylline relax the lower esophageal sphincter, so it causes more of gastroesophageal reflux. So if the patient did have a little gastroesophageal reflux, you start treating them with beta-2 agonist or theophylline. The gastroesophageal reflux get worse, and the patient symptomatology also gets worse. Though asymptomatic gastroesophageal reflux are not likely to cause a poorly controlled asthma. So if you find your asthmatic patients not getting good control, and you're treating them with a fair amount of medication, you have checked their inhaler techniques, do look for gastroesophageal reflux. Psychiatric disorders, one which is quite commonly seen by all chest specialists, that patient's family come with the patient, and the patients go into panic attack, which is quite often mistaken as an acute asthmatic attack, but it's quite simple to differentiate that an asthmatic attack takes a longer time to resolve. Patients usually have wheeze, but a very severe asthmatic attack may not have wheeze and have a silent chest. So before labeling a patient with a panic attack, one needs to be like really sure. But then apart from panic attacks, the other smaller psychiatric disorders like depressive disorders or anxiety neurosis, which is not amounting to panic attacks, also influence asthma. How? There are worse asthma symptom controls. These patients have a bad adherence to medication, and because of these two things, they have a worse asthma related quality life. So they have a significant amount of uh, disability, adjusted life years, and they have a worse quality of life attribute, and that is attributed to their asthma. Upper airway disease. Upper airway disease evidence clearly support a link between the upper and the lower airway disease. People, people who have allergic rhinitis or a non-allergic upper airway disorder, they have a higher requirement for their medications and difficult to control. One which is quite common is allergic rhinitis. And allergic rhinitis, as we all understand, could be seasonal, could be perennial, or could be intermittent, depending upon what kind of an exposure is causing that. So you may have a patient with intermittent allergic rhinitis, and that could be because of a third part. The patient has a cat or a dog at home, and that causes both the things as a worse allergic rhinitis as well as asthma. So we need to like have a proper history about it. Ruling out allergic rhinitis is paramount importance. Once you're going to start asking patients, you will find that there is a significant number of patients attending your OPD who are asthmatics, does have allergic rhinitis, or patients who have come with allergic rhinitis symptoms have bronchial asthma along with it. So if you, this is like quite a busy slide, but then all that we need to understand is that it's a prevalence of comorbidities in asthma and non-asthma patients, and it has been seen that what kind of prevalence is the prevalence of all these things like cardiovascular, cerebrovascular, hypertension, diabetes, obesity, endocrine, psychiatric, gastrointestinal or urinary, respiratory comorbidities, cancers, arthritis, other diseases, are they more common in asthmatics as compared to control or non-asthmatic patients? And if you see, the p-values have been like significant in all. So it's like this is like quite a interesting study which came in, and does requires more of investment in terms of understanding these links. But then that's like quite a serious thing. Everything is more common in asthmatic patients. They are more prevalent in asthmatic patients. So when you're talking of asthma, you're not just talking of asthma. You're talking of other diseases also, which could be present, and a cancer may not directly affect asthma, or a endocrine disease may directly affect asthma. But then we have to have that in back of our mind. It could also be because of that these patients are getting continuous care because of their asthma, that they are being diagnosed more often. That could also be a possibility. And then coming to association of adult onset asthma with specific cardiovascular diseases. So these are all cardiovascular diseases which are said to be a total cardiovascular disease, a stroke, congestive heart failure, or coronary heart disease. And adult onset asthma was associated with a significant higher number of cardiovascular diseases, but the association was not seen in child onset asthma, a childhood onset asthma. So this is like quite interesting, and we need to like look into it, that patients who have adult onset asthma may be screened for cardiovascular diseases also. And does asthma has a contribution towards mortality in cardiovascular patients? And the study which was published in Annals of Saudi Medicine showed that the asthma was associated with increased risk of cardiovascular disease and all-cause mortality. So it is not just concomitantly being present with asthma, but it is also associated with higher mortalities. So probably there are certain links that we still don't understand and we need to decode, which is leading to not just being present in more numbers in asthmatics, but is also leading to deaths of these patients, increased risk of deaths to these patients. Coming to a study which was published in Journal of Allergy and Clinical Immunology in 2009, and they talked of cardiovascular disease risk associated with asthma and respiratory morbidity, and is it being mediated by the short-acting beta-2 agonist that we are using? So there is a significant talk which is there, and that does a short-acting beta-2 agonist cause more of cardiovascular disease risk as well as morbidity and mortality. And now, as we understand, there has been a lot of debate happening at all platforms that whether SABA is out in asthma care or not. And recently, I was attending a panel discussion which half of the panelists did agree that we should now get away from short-acting beta-2 agonist, but the other half said that we have managed asthma and then there is still space left for short-acting beta-2 agonists. So there has been a paradigm shift in GINA 20, which says that now we don't treat any of our patients with only short-acting beta-2 agonist, and it is preferred that all patients should get an ICS. Even if it is SOS, we should prefer a LABA plus an ICS rather than giving them a SABA alone because of increased risk of life-threatening acute severe attacks in mild intermittent asthma. So we have started thinking of having a whole paradigm shift, which is quite interesting. Now, many a times in our setup, we don't really understand the disease process in patients because patients' previous history is not recorded anywhere. Whatever patient comes and presents to us, we can't cross-check it. Unlike Western world, where they have a very good OPD recording systems, which is shared between doctors. So that becomes even more interesting in our country. When patient doesn't reports, tells us, doesn't comes all the time, gets treatment from chemist shops, that do we need to really treat them with only a SABA when there is an increased risk of morbidity and mortality associated with SABA? Or we should switch to a LABA ICS even in mild intermittent asthma. So the debate still goes because GINA has also left a little space and has kept SABA still there in the step 1 management, though not the first choice, the second choice, but we are still waiting that it is like erased or it gets an equal share in that. Then coming to the most confusing part of the talk, coexistence of asthma and COPD. So I promise you I'm going to confuse you more with the coming slides as the subject is equally confusing. So when you call COPD when the patients have an age of more than 40 years, they have a history of smoking, which is quite difficult because in India we see non-smoker COPD to be equivalent in numbers as the smokers COPD. So in India, we found a lot of people who have COPD have never smoked. So that definition of smokers getting COPD makes life even more difficult, especially in such patients where you have obstruction and reversibility and they have not been smokers at any point of time. So there are certain characteristics of fixed airways, but airway reversibility, which is labeled as an overlap. And do we need to treat them differently? COPD, asthma differently? Does asthma, COPD overlap exist? And do we need to give it so much of importance that we talk about it and try to understand the difference in our patients? So this is an interesting slide which is going to put up the whole conversation that I was talking of. So if you see, it's like that there are three parts of understanding it. Is it like a discrete entity? So one is asthma, the other is COPD, and one which has features of both is asthma COPD overlap. Or is it like a continuum of the same? It is like continuum of a airway disease. T helper 2 cells, cytokines, IgE allergens which do that, and you have an asthma phenotype. T helper 1 cells, cytokines, and it's like smoke exposure, pollution exposure, emphysema, breakdown of the alveoli, the COPD phenotype. And if they lie in between, they are echo phenotype. So are they like continuum of the same disease, two extremes, and the middle part is the echo phenotype? Or the third is that they are just coincidental. They don't have any relationships between each other. And they are like coincidental, that when as environment caused COPD and then genetics caused asthma, and when an asthmatic had COPD, it became an asthma COPD overlap. So you understand, it's like we don't have an answer to this, that is it a discrete clinical entity? Is it like coincidentally present in one patient? Or is it like a continuum of airway disease? It's like a spectrum of the same disease. Then an interesting study which came in Respiratory Research 2019, and what they talked of was they did a systemic review to understand what is the prevalence of asthma COPD overlap, and they did found that there was 2% of general population which was affected with asthma COPD, but then there was a problem with it. There's a problem like that the diagnostic criteria are not very well defined with echo. So are we like really looking at the right picture? And as per GINA 2020, the diagnosis made by doctors as asthma and COPD has been reported between 15 to 32% patients who had one or the other diagnosis. So there is a very difficult situation that we see. So the diagnostic criteria which were proposed by Peebles in current allergy and asthma reports in 2017, that there are three major criteria and there are three minor criteria. And if the patient has all three major criteria and at least one minor criteria, then you call them a cause. And what are the major criteria? Persistent airflow limitation of FEV, which is classified as an FEV1% of less than 70%, and the patient's age is more than 40. There is a significant smoking history which is there, or more than 10 pack years, and there is a document history of atopy or asthma, or a bronchodilator response of more than 400 ml in FEV1, not 200 ml, 400 ml in FEV1. And the minor criteria had documented history of asthma or allergic conditions, bronchodilator FEV1, and peripheral eosinophilia. So the problem with this definition in India is that more than 50%, around 50% of our patients who have COPD doesn't have a history of smoking. So that makes it difficult. So the confusion still is there, and it has not been totally corrected by the criteria that has been put in by Hines and Peebles. And to make that more confusing, Mirabetlis put in 5 commandments And I'm going to read those 5 commandments, which will actually confuse you more. That a patient with asthma may develop non-fully airway reversible airflow obstruction, but this is not COPD. So why these 5 commandments came in? The 5 commandments came in because what is the difference? What is the basic difference between COPD and asthma? The basic difference between COPD and asthma is that asthma is a non-progressive disease, right? If you don't treat it, there may be a burnt out airway, or there may be like a non-reversible airway, which is called as remodeled airways, could be there. But unlike COPD, this is not non-progressive, but COPD is a progressive disease. So as the time is going to go by, the FEV1 is going to continuously fall, and the fall in the FEV1 will be more than the normal fall with age. This is what is COPD. So that is like the basis of 5 commandments. That it's like not just the obstruction that we are talking of. It is about the progression also that we are talking of. So even if an asthmatic patient develops a non-fully reversible airflow obstruction, this is not COPD. It is even not echo because it is not progressive. In echo, it will be progressive disease, but it is obstructive asthma. So still you have not sealed him as an echo or a COPD, that this is progressive and this patient is going to die because of an fall in FEV1 which is progressive. A patient with asthma who smokes may also develop non-fully reversible airflow obstruction, which differs from obstructive asthma or pure COPD. And a patient who smokes and develops COPD may have a genetic T helper 2 background, as I told you, and can have a high eosinophil count in peripheral blood, but these may not be included all the time as an overlap. But then these patients are the more likely patients where you can like put them under the umbrella term of an echo. And then a COPD patient with a positive bronchodilator of more than 200 may be a reversible COPD but not asthmatic, as it is going to progress over a period of time. And a patient with COPD and positive bronchodilator test is more likely to have some features of asthma, and it could be classified as an echo. So this is like something which is like saying the same thing as the classification that came in the diagnostic criteria that came in the last slide. So if you see, there are a lot of talk happening about asthma COPD overlap. People are trying to define it. And why they want to define it? Because the individuals who have asthma COPD overlap have poorer or outcomes as compared to normal asthma patients. So that does make a lot of valid points to differentiate between the two, because then you can actually differentiate that who's going to die because of this disease or not, and which is going to have a poorer outcome. It's quite a busy slide. There are only 2 things that I want you to understand. If it is asthma, treat as asthma. If it is asthma COPD overlap, still treat it as asthma. And what is the most important thing in asthma management? Inhaled corticosteroids. And you don't give them a long-acting beta-2 agonist alone, unlike COPD where you give it. Why? Because patients, when are treated only with beta-2 agonist alone, they have a higher risk of dying with an acute severe attack. So this is like the crux of the whole slide, which is there. And if it is COPD, then treat it as COPD. So a COPD asthma overlap, treat it as asthma. And now, because things are very confusing, we need to look at treatable traits. What treatable traits for asthma, COPD or echoes? You look for airway obstruction and you want to treat it. So you can treat it, if it is COPD, then you treat it with LABA monotherapy or a LABA-LAMA combination. And you give ICS only in those conditions where you have seen an eosinophils. But when we are talking of asthma, and you are talking of asthma with an airflow obstruction, then you never give them a LABA monotherapy. So either you give them SABA or a LABA plus ICS if they are the non if step one intermittent, then you give them SABA, but then the GINA 2020 says that you give them an ICS plus LABA in all the cases. If there is an exacerbation, frequent exacerbation with eosinophilia, then ICS is going to help in both the patients. Then you have other options also of anti-IL-4, IL-13, IL-5 being as in potential form if they have eosinophilias. If they have high IgE, then you treat them with anti-IgE, which is omalizumab. Then neutrophilic inflammations, if that are associated, that are like causing more frequent exacerbations, then these patients may require macrolides, and that may help them over a due course of time. If the patient has emphysema and severe air trapping, then one may consider lung volume reduction surgeries in such patients or endobronchial valve, lung volume reduction with valves or coils. If the exacerbations are refractory to all these things, then bronchial thermoplasty may help. So we have a little bit of option, and that is why we need to get into more of other treatment, understanding other treatment modalities also. It is not just steroids and ICS LABA, steroids, ICS LABA. We have a lot of options now. So we need to look into it and find the indications and treat them accordingly. If the patient has allergic rhinosinusitis, if it is, then nasal steroids help. Or if there are polyps there, surgery helps. Polypectomy does help. But then it has to be treated concomitantly with, along with surgery with nasal steroids. Otherwise, there are recurrence seen. Patients with nasal polyps have a worse symptom asthma control as compared to the non-polyp allergic rhinosinusitis patients. Obesity, if lifestyle modification doesn't help, bariatric surgery. Physical deconditioning, pulmonary rehabilitation. Smoking habit reformation is very important, and if we can actually make patients quit smoking, things can become better. So there are behavioral interventions and pharmacotherapies too. We are always underdoing the smoking part. We do advise our patients, but we don't, it's like we are not only advising, not helping them through. So we need to have a good smoking cessation program in place at all respiratory centers. And we should also incorporate pharmacotherapy alone. Behavioral interventions or advice don't help. And then the psychiatric problems need to have psychological interventions, pulmonary rehabilitations, as well as pharmacotherapy. So if you see, the red line is near the red line, away from the red line, more away from the red line, more chances of asthma COPD patient to have other illnesses. And this is it's like compared. So you see nearly all disease have more of a prevalence in asthmatic disease patients as compared to non-asthmatic patients. Now, whenever you're treating asthma patients, you need to look for comorbidities, and then you also need to look at modifiable factors. Modifiable factors are very important, and if you can address the modifiable factors, then you significantly reduce morbidity in asthmatic patients, as well as you prevent them going into acute attacks and mortality too. So patients having molds at home are like one of a very important thing you need to like look for, that are there any molds. dampness at home, sealant to nahi hai, and then that is like something which can be corrected and things can become all right. So there are like comorbidities affect asthma, asthma affects the comorbidities. In poorly controlled asthma, the use of systemic corticosteroids, reduction of activities and exercise, poor sleep quality all contribute to a worse diabetes control, depression, and obesity, which in turns which in turn affects asthma. So it's like a vicious cycle either ways. Then it's like one affecting the other. It's like both the things affecting each other. We need to like look into the comorbid conditions, and there are so many asthmatic patients who are obese, have sleep apnea, but a sleep study has never been advised to them. So one should not get away with a habit of having one diagnosis and settle on it, and don't look actively for other comorbidities. Sometimes a patient may feel better and may also not complain of other things except for adjusting with it. So one needs to look for it. So this is like quite an interesting slide, a pictorial slide of interplay between comorbid conditions and how it complicates. So these are the conditions which are there. These are the four state conditions. A differential, it falls into a differential diagnosis, or does it affect the asthma control? Does it lead to exacerbations, or does it cause any change in the lung function? So if you saw vocal cord dysfunction, it comes into differential diagnosis. Many of vocal cord dysfunction patients doesn't have asthma. Their intermittent breathlessness and cough is because of vocal cord dysfunction. If it is concomitantly present, it does affect asthma control, and it does lead to exacerbations also. The smaller one is a kid, the purple bigger one is an adult. So it's like differentiating between, it's like talking about both adults and pediatric populations. Obesity does comes into differential diagnosis also. Patients with obesity may be very breathless because of restrictive lung disease, or it may also affect asthma control. Obstructive sleep apnea may also, patients with obstructive sleep apnea may have incessant cough not getting controlled with anything, and it may have, if it is concomitantly present, then it does have an effect on asthma control. Allergic rhinitis, it does have an effect on asthma control. It does lead to exacerbations and affect lung functions too. People with nasal polyps or rhinitis have been seen to have worse lung functions as compared to patients without having allergic rhinitis. Psychiatric conditions, asthma control as well as exacerbations are affected because dependence on their medication, the adherence to their medication, is less. And GERD has effect on all four things. It does comes into differential diagnosis also. It comes in it comes into, it plays a worse role in asthma control, exacerbation, as well as lung functions. So comorbidities may influence severe asthmas in various ways. It may influence a phenotype like obese asthmatics, smoker asthmatics, an aspirin-induced asthma, or an allergic ABPA, allergic bronchopulmonary aspergillosis associated asthma. So these are various phenotypes which could be there, and you need to like differentiate them in your differential diagnosis. If it is like, it could be a concomitant allergic rhinitis which is present, it affects both the diagnosis as well as the control. And environmental exposures like occupational asthma is important to understand. People working in a place where they are exposed to those allergens, or smokers asthma could be there. If there are more number of comorbidities and difficult to control asthma or non-difficult to control asthma, if you see, if the patients have no comorbidities or less comorbidities, then difficult to control asthma is less. But when they have two, three, two or more than two comorbidities present, then they are the numbers to difficult to control asthma is more as compared to easy control of asthmatics. And if you see diabetes, obesity, so in this slide, if you see diabetes, obesity, nasal polyps, anxiety, cardiovascular, GERD, all these lead to a higher difficult to control asthma, out of which cardiovascular diseases and gastroesophageal reflux are like the toppers. So asthma management cycle as proposed by Gina, that you review response, assess and adjust. What do you assess is comorbidities. You look for modifiable risk factors and correct them. And that is how you have an effective control of asthma. How do you do so? You may do an allergic skin testing. You may refer a patient for rhinoscopy, a sinus radiography, or a computer tomography, NCCT, PNS. If there are recurrent exacerbations happening, do a bacteriological testing of sputum. Look for a therapeutic trial for gastroesophageal reflux with PPIs. If you can do a pH probe study, very nice. If you are suspecting sleep apnea, do a sleep study. Look for precipitants for aspergillus if patients have very high IgE levels. Do pulmonary function testing. Chest radiography, CT, bronchoscopy may be indicated in few patients, not all of your patients. And do a laryngoscopy, his psychological evaluation, or induce sputum cells. So and then you treat them accordingly. Allergic rhinitis, you treat them with allergic rhinitis. Apart from other things, immunotherapy do help, but trying them in patients with asthma, it is still like something that we need to understand. But allergic rhinitis, immunotherapy does help. And LTRA also helps a lot in these patients. Rest are all. In GERD patients, you do a PPI. In obesity patients, you try lifestyle modifications, weight reduction measures, or bariatric surgeries. Obstructive sleep apnea, you put them on weight loss regimes and a CPAP. That is how you approach them. The most important out of these is vocal cord dysfunction. So you need an ENT referral for that. Do a laryngoscopy, get a laryngoscopy done. And speech therapy is very important in vocal cord dysfunction, which is one of the most difficult patients to treat. So choosing a cardio-safe molecule for asthma, it's like something which is a very controversial thing. It's salmeterol fluticasone. Is it like a safer drug as compared to formoterol fluticasone? We really don't know. There are trials which say that both are equally safe in patients. So my concluding remarks are that comorbid conditions may influence the diagnosis and assessment of severity and control of asthma. Comorbid conditions and asthma may result from or be influenced by similar pathophysiological processes like rhinitis, OSA, or they can modulate the asthma phenotype. Identification and treatment of comorbidities is now recognized as an integral part of core management of asthma, particularly in more severe forms of disease. So asthma can be defeated, but only if we treat the whole person in front of us and not just the lung disease. Thank you so very much. The dais is all yours, Adit.
Thank you, sir. So we have some questions from the audiences. The first question is from Dr. Asha. The question goes like, what percentage of weight loss can help improving asthma symptoms?
That's a lovely question. So any amount of weight loss is going to help asthma. It is as per the patient, what BMI patient has, and then the patient should reach into the desired BMI.
Right, sir. So the next question is from Dr. Ashutosh. If a pregnant woman develops asthma during, is there a higher risk of developing childhood asthma in the children?
In the children?
Yeah. Should I repeat the question?
Yeah, please.
If a pregnant woman develops asthma, is there a higher risk of developing a childhood asthma?
So this is quite an interesting thing, subject to understand. Pregnancy does have an influence on asthma. So 1/3 of pregnant females will have worsening of their asthma symptoms. 1/3 of pregnant females, their asthma will get better. And the rest 1/3, their asthma will be same as before. So why? We don't understand that. Asthma does have a genetic influence, and it is not a genetic disease, it has a genetic influence, and the environment does have an important role to play. So when both the things put together, yes, people with history of asthma may have offsprings who will have asthma. But does that really means that all children of asthmatics will have asthma? No, it is not like that. But then atopy does run in family. So yes, there is a higher risk of getting asthma.
Then, so the next question is from Satish. He's saying we often get patients who are on orals plus SABA. What is your call in current situation?
Oral corticosteroids plus SABA.
Orals plus SABA. It could be, I don't know, it could be a theophylline kind of drug. He's saying how we often get patients who are on orals plus SABA. What is your call on these patients?
So I never give any of my patients short-acting beta-2 agonist alone. Either it is a smart therapy, a LABA ICS continuous use plus an SOS LABA ICS use, or it is like a LABA ICS plus SOS SABA. So alone SABA should never be used. That's the first principle of treating asthma. And the second thing is that always try switching your patients from oral to inhaled, because inhaled therapies have been proven to be better as compared to oral medications. It may take a little longer, you may lose few patients, but if every doctor says the same thing, nobody will lose patients. And then the most important thing is benefit of patient. So we should always be thinking of welfare of patient. That's the reason you all are attending this session. It's all for the patient's welfare. And SABA and oral medications should be discouraged, and inhaled therapy should be encouraged. An adjuvant along with inhaled therapy in difficult situations may be used.
Right, sir. Another question is from Dr. Walvekar. The question is, patient is on highest dose of ICS LABA. What is your criteria of adding up LAMA or OCS or per se moving up to MABs?
Moving up to?
MABs, MAB, monoclonal antibodies. Yeah.
Okay. So that's a nice question. So if the patient is on highest dose of corticosteroids, then once a patient is on higher dose of corticosteroids, whenever you approach, this is difficult asthma, so like difficult to control asthma. So you have a definite approach to it. The approach is the basics first. Look for your diagnosis. If your diagnosis is correct, you're not missing something. You're not missing comorbidities. You're not missing, it's not a vocal cord dysfunction. It is not, there is no cardiac involvement into it. It's not a cardiac asthma. So you first confirm your diagnosis, rule out the comorbidities. If there are comorbidities, treat it. If you have done all that and you're sure that now everything has been put all right, look for device use, how the patient is using the device. And when everything is done and still the patient requires a higher dose of steroids, then you classify them into eosinophilic. First, you classify them into atopic and non-atopic, and then you classify them into eosinophilic or a high IgE. Those patients with a high IgE or eosinophilic who have gone to the step 4 and they are not getting better with it, there you consider using the MABs. And using a LAMA, I would prefer using a LAMA before MABs because it is less costly and it does help in such patients. If you add a long-acting muscarinic antagonist like a glycopyrronium or a tiotropium, you do find these patients to improve. So there is definitely increased vasomotor tone in the bronchus, and these patients get better symptomatically. If the patients are not getting better with LAMA, then of course go on to MABs because MABs is a costlier therapy in our country. If the patient can afford it, then of course preferring a MAB is a better thing because then you can actually bring down this corticosteroid doses. So if affordability is not an issue, give a trial of MAB, that's better. If affordability is an issue, use LAMA and then switch because LAMAs will not help you bring down the corticosteroid dose. You will have a symptom control with a higher dose of corticosteroids.
Right, sir. The next question is from Dr. Bhandari. How often you give oral antibiotics in severe asthma exacerbation cases, and what is your therapy duration on an average?
So acute severe bronchial asthma, the antibiotics preferred depends upon the usage of antibiotic that has been done in past. So if the patient is therapy antibiotic naive for the last 3 months, has not been admitted into a hospital setup or emergency setup and has not received antibiotics, so amoxicillin clavulinate, augmentin, and a macrolide is preferred, and for a 5 days duration. If the patient does have a bronchiectasis along with asthma and have a acute severe bronchial asthma, then we need to cover Pseudomonas. So either anti-Pseudomonal cephalosporin or anti-Pseudomonal penicillin needs to be given along with a macrolide. That is how you treat them, and then you treat them as per the treatment. If you have a Pseudomonas which is multi-drug resistant, then you give for a 2 weeks therapy, or otherwise 5 to 7 days therapy is said to be enough.
Right, sir. So the next question is from Dr. Rajendran. He's saying, is there any correlation that difficult to treat asthma may further develop into fibrosis or even lung cancer?
So not too much of studies to suggest that asthmatic patients progress into lung fibrosis. Whatever fibrosis does happens into the airways, which is quite different from lung fibrosis. In lung fibrosis, the interstitium is actually affected. In these patients, asthmatic patients, it is the airway which gets fibrosis, which is called remodeling of airways. And cancers, asthma is still not labeled as a risk factor for lung cancers.
Right, sir. The next question is from Dr. Satish again. Is there a correlation of alcohol intake and asthma severity?
Alcohol intake will always increase gastroesophageal reflux, and the gastroesophageal reflux may indirectly affect asthma control.
So the next question is, how well does management of comorbidities reduce severity of this disease?
So if you miss a comorbidity and you are into a private sector, the patient will not follow you after 3 months. That is like the severity of comorbid. That is like how severe a comorbidity not being treated may be. And if you treat comorbidities, still there will be certain patients, a very small subset of patients, who despite treating for their asthma as well as comorbidities may not have well-controlled asthma, and they are corticosteroid. They are the real difficult cases, which are like corticosteroid-resistant asthma, and they may require further therapies for asthma. But 95% of the patients, in fact 98% of patients, when treated for asthma along with their comorbidities, are well controlled.
So this happens to be, I believe, the last question, unless I refresh the screen. Which is the most common asthma phenotype in your practice?
The most common asthma phenotype is the normal asthma. The second most common is allergic rhinitis or oculo-nasoocular allergy along with asthma. That's the most common phenotype that we see. But then, as as the smoking habit is going up, the whole world is quitting smoking. Incidentally, Indians have started smoking more. The smoking pattern in India has is on rise. And contrary to the Western world, where the smoking patterns in youngsters have gone down, so that phenotype may also come up. And now we are seeing a lot of patients being diagnosed for COPD, so asthma COPD overlap phenotype will also be seen more commonly because we are like doing more of pulmonary function test. It's like a table spirometry has become so popular that nearly like GPs also do have that in their offices, clinics. So we will also see a rise in number of echoes, but then most common is the simple asthma and the second most common is with allergic rhinitis.
So one more question has come, this time from Dr. Harfun. He's asking, do you recommend prescribing intranasal corticosteroids in asthma patients who are already on ICS LABA?
I didn't got the question. Can you repeat?
Do you recommend prescribing intranasal corticosteroids in asthma patients who are already on ICS LABA?
So if the patient has allergic rhinitis, yes, of course. Why? Because the ICS lava is going to go into the lungs, into the airways. The nose is not going to be like catered by the ICS lava. So the patient needs an intranasal spray, intranasal corticosteroid for allergic rhinitis.
Right, sir. Thanks. These were all the questions from the audiences. Now I hand over the session back to Aditya. Aditya, over to you, please.
First of all, thank you so much, sir, for giving a valuable time from your busy schedule. And thank you for sharing your knowledge and describe so much about asthma and COPD and all new guidelines on COPD, particular GINA 2020 and therapy knowledge. And on the behalf of the Lupin respirators, thank you to all respected doctors who have joined us in this particular program, Respi Talk 2 series. Thanks a lot.
Thank you, Dave.
Thank you, sir. Thank you very much. Dinesh, you may please disconnect now. We are offline. Thank you, Aditya. Thank you.